everyone, and welcome to Rad Chat, the first therapeutic radiographer-led oncology podcast. So welcome to podcast number 42. My name's Jo McNamara and I'm joined by my fellow host, Naeem Angelka Anderson. So a big thank you to our last guest, Dr. Emma Hyde, who talked about personalised care in radiography. If you haven't had a chance yet, please do go and take a listen. So we're really pleased to introduce our guests for this evening, Catherine Holborn and Emma Hallam, who will be discussing survivorship, late effects and supported self-management. So evening, ladies. Thank you for joining us.
Hi, Jo. Hi, Naaman.
Hello there.
So, both of you, I feel very privileged that I kind of know you both quite well. But for the audience, do you want to tell them a little bit about yourselves and your current roles?
Do you want to go first then?
You go first, Cath.
Oh, fab, thank you. Hi everyone, my name's Catherine Holborn. I work as a senior lecturer in Radiotherapy and Oncology at Sheffield Hallam. I'm still registered with the HCPC as a therapeutic radiographer, and the majority of my role at Sheffield Hallam is in the delivery of our post-registration MSc provision, and I've recently taken on the role as a training and education lead for our Advanced Wellbeing and Research Centre as well, which is sort of aligns nicely to this topic.
Okay, so I'm obviously Emma Hallam, as you know, and I'm a consultant therapeutic radiographer at Nottingham, and I lead the Nottingham Late Effects Service, which is a bespoke service for anybody who is experiencing a physical or psychological effect as a consequence of their radiotherapy and or chemotherapy treatment. And I also work really closely with Sheffield Hallam University, providing education for on late effects and supported management through radiotherapy and living with and beyond cancer.
Perfect. So both two very different roles, but working synergistically together. And actually, Cath has a lot to be responsible for, because I'm only a lecturer because of Cath. Because she was like, Jo, I'm drowning in marking, will you help me? And that was my first ever little insight into being a lecturer. So Cath, a lot of students are probably going, oh no, she's responsible for that. So Cath, we'll start with you. Can you tell the audience a little bit about your kind of career pathway to date and what got you into lecturing?
Okay, so, well, I started a long time ago as a qualified therapeutic radiographer, so I actually trained with Emma, so we've known each other a long time. We qualified in 1998, and I started work at what was the Cookridge Hospital in Leeds, and sort of obviously worked there as what would be now classed as sort of band 5, going to sort of band 6 role, and then moved to Nottingham, where back then it was sort of a senior 2 superintendent team leader type role that I worked up to. Again, working with Emma, our paths crossed again back at Nottingham. And I suppose back then there wasn't a lot, well, advanced practice wasn't really a thing. The 4-tier structure was just coming in, but it was more focused on assistant practitioners at the time and implementing at that level. And yeah, there wasn't really, you either went in sort of education or sort of more sort of leadership, sort of outside of the clinical environment with, if you wanted to progress any further. And I'd always enjoyed this sort of the teaching side of things, the education side of things, and yeah, it just everything sort of fell into place really. There was an advert for a lecturer post at Sheffield Hallam. Like I say, it was something that I really enjoyed, the teaching side, supporting students on placement. So I sort of thought, well, I'll give it a go. And long story short, started in about, I think it was 2003 at Sheffield Hallam. So I've been there a long time. Pretty much contributed to all aspects of our provision, and yeah, over the years I've sort of developed my own areas of interest, firstly into sort of the post-registration master's level side of things. Really enjoy that side of my role, and over the years my areas of interest have developed towards prostate cancer firstly, so do a lot of work with Prostate Cancer UK as well, run the MSc in prostate cancer care, deliver modules associated with that. And more recently, I really do have a keen interest in the whole sort of cancer survivorship, personalised care agenda, and sort of the topics that need to be delivered aligned to that, really, including things like advanced communication is a really big one as part of that. So yeah, I think that's me.
Perfect, thank you. So Emma, do you mind giving us a bit of a rundown of your career pathway?
Yeah, so I qualified back in, I think it was 98, Cath, we did qualify. And I first worked at Leicester as a radiographer grade and then senior 2. And then I moved to Nottingham. And, was really, a treatment radiographer. I loved that role, but my passion has always been around the information support arena, really, if I'm honest. So I quickly became a Super 4, as we called it in them days, and then I decided that I wanted to move into information support and rad review, and I never looked back, if I'm honest. I absolutely love going above and beyond and supporting the patients. I started my role in information support really supporting breast cancer patients through treatment, and then I was really fortunate that a position came up in head and neck. And I was like, I really want to get my teeth into something that's a bit more gritty. And at the same time, I was offered to, by one of the consultants, Dr. Judy Christian, to set up and develop the Nottingham Late Effects service. And that has just been the most humbling experience that I could ever imagine. I absolutely love cancer survivorship, helping patients when nobody else knows what to do with them. So I've been really fortunate to have this position. I've been really fortunate to have Cath by my side throughout all of this, who has supported me all the way through my masters, because I always go, I can't do this, through my non-medical prescribing and also through my advanced clinical assessment skills. And Cath has really been a driving factor in my academia side of everything, and also the support from the rest of the staff at Sheffield Hallam. So it's been a really working relationship, and it's really good that I can now give some of that back, my clinical expertise in supporting the different lecturers on their modules and things. So I really enjoy that side, the education side of it as well.
Oh, it sounds amazing. Very long careers so far. I'm not going to say what I was doing in 1998. So Cath, you've talked about some of the modules that you're involved in at Sheffield Hallam University. You talked about survivorship. Just for anyone, what is survivorship and why is it important?
So I suppose if you think of survivorship as a very broad term, first of all, so survivorship encompasses all people, patients, but also their family members, their loved ones, that are really sort of living with the consequences of cancer and its treatment. So I think probably everybody knows this by now, but it's certainly not just limited to those that have maybe had an early cancer diagnosis, have had their treatment, completed it, and then sort of you're in that sort of classic follow-up survival type period. It really does encapsulate everyone across the disease trajectory. So it should incorporate care for those that are with more advanced cancers, having continual treatment, lifelong treatment sometimes, coming back for treatment because of progression. And it should also encompass and aligns very nicely actually to the principles that have been around for a long time in the palliative care setting, but it should also encompass those, within the palliative care setting as well. And it's really, in terms of survivorship care, it's really about enabling people to have as good a quality of life as possible in the context of those consequences that they are living with, because of their cancer and its treatment. And I think, so a common term that's often used instead of survivorship is actually, we're helping them to thrive. So patients themselves will often use that term because it really is about the importance of giving them that quality of life and allowing them to thrive, but it's not about equally setting up unrealistic expectations as well. And it's about acknowledging that it is very much allowing them to thrive by coping better and managing the consequences of their cancer and its treatment more effectively with support from us, but also bringing in the whole sort of self-management side of things as well. Another term that I like is sort of this supporting them to adjust to a new normal, and I think that really encapsulates for me survivorship care as well. So it's recognising that we do change their life. The cancer changes its life, the diagnosis of cancer, but also our treatments, they are life-changing, even if in just a small way. You know, a popular topic at the moment is rehab, and Emma and I often have discussions about this. It's certainly not about rehabilitating back to what life was before a cancer diagnosis, and I think that's a really important principle to take away from, I suppose, this conversation we're having now in terms of what survivorship care is. I think in terms of why it's important for me, obviously there's the whole thing of there's just so many people now that this covers in terms of our treatments advancing and many more people living with cancer and its effects, and we have to find ways of supporting them effectively that makes the best use of our resources and getting them the help, the specialist help when they need it, like with Emma, but also getting better at enabling self-management as well. But I think ultimately for me it's important because of the consequences, because of the quality of life impact, and we do have a duty of care to not only treat them and hopefully control or cure their cancer, but we do leave them with life-changing consequences, and we have to support them to live with those. That is my sort of passion, and Emma's too. I think everybody knows that it's, you know, that we know about the physical, and we know about, I think all of us understand the holistic impact of that it has then wider consequences psychologically, socially. I think sometimes is forgotten. I don't know what Em thinks on that, but you know, the social impact, whether that's financially, work-wise, being isolated due to their side effects, not wanting to engage with their friends anymore, their family, it can have such a massive impact socially. I think people recognise that, the holistic side of things, and survivorship care is very much about a holistic approach, but I think it's more than that now. So again, in terms of survivorship, as you guys know, the terminology, as was probably discussed in the last podcast, is more around personalised care. So it's also about recognising that, you know, people have these consequences. In fact, you know, if you were just to look on paper, you know, there's populations of patients that will have a certain consequence of their treatment, whether that be a physical effect or the psychological issues that go along with that. But then every individual person has their own personal experience of that. And that's influenced by those sort of wider social determinants of health as well, their own life circumstances, what's important to them, where their preferences lie. And really that's the direction of travel in terms of survivorship care now, sort of really seeking to understand what matters most to that individual, and trying to tailor our treatment and care around that. So yeah, hopefully I've answered your question there. I think the one thing I just wanted to one other thing I was wanted to say before we go, which I think will lead nicely on to Emma's, is personalised care. That if you read the literature on that, and I'm sure it was discussed last time, you know, supported self-management is a big part of that. But it isn't just about, and as part of that, you know, it is about, you know, advice around things they can do to live healthily and support themselves. But, you know, in terms of managing the consequences of treatment, the provision of late effects services is just so important, and a big part of supported self-management. So I think when we talk about supported self-management, we think of, it's not just about giving advice to help patients manage, you know, do the more simpler things to help manage and cope with their condition. It requires support, and sometimes specialist intervention depending on the severity of their side effects, and I suppose that's what we're obviously here to talk about tonight, the sort of the late effects management side of things to survivorship care.
Cath, that's really interesting what you've kind of commented on, and I genuinely think some people may not necessarily know what that is.
So I mean, I suppose in terms of helping I mean, it can be basic things. You know, I don't want to move away too much from the late effect side of things, but, you know, more generally, it's important to engage patients in discussions around the importance of physical activity, for example. So that can be beneficial for so many reasons, and it can even be targeted physical activity exercises such as pelvic floor exercises to help manage incontinence, for example, for pelvic patients. But yeah, physical activity is a big part of the self-management agenda, but it can also be about making sure that they're able to navigate support resources around getting support for financial, vocational support out there in the community, signposting them to peer support resources. Signposting is a big thing, I think, if you're not in a specialist role, to be able to signpost people to good quality resources. The charities are a good resource for that side of things. But yeah, a general self-management, you've kind of got the general side of things and then the more targeted, depending on the consequences you're trying to manage. But the general side of things are to do with sort of encouraging that engagement in physical activity, good nutrition, and I suppose also, I mean, Emma will be able to sort of perhaps talk about this as well, but, you know, sort of giving them the tools to sort of manage their emotional well-being as well, you know, assuming that they've not got a more severe level of psychological distress, it's kind of giving them the tools to sort of manage psychologically as well, relaxation techniques, mindful, you know, those kind of signposting to that kind of resource. Just giving them the tools after treatment to sort of help themselves. A big thing is, and again, this links to what Emma's going to talk about, I think, is, you know, when they finish that particular treatment with you, say, for example, you know, the importance of them being able to understand what a late effect is. When they might need to, you know, the importance of reporting that at follow-up, knowing where they can get help when, and that they can talk about consequences that they're suffering from, and know that there is hopefully help out there with that. So early identification of late effects is a big part of that, and the patients can play a role in, you know, self-reporting their concerns.
Tell us a little bit about the late effect service that you run.
Yeah, so we set this service up back in 2013, and when we originally set the service up, we really thought we were going to be inundated with pelvic patients, because that's where a lot of the work had been done around pelvic radiation disease, and it became very clear very quickly that actually there was as many, if not more, head and neck and breast patients who were really struggling after they'd finished treatment. So we already set out saying we were going to see any patient, but we really focused, we thought, on pelvis at the start, but we really realised that we had to expand this. And if anything, I'd say they've probably overtaken the pelvis patients. What I think is really key is to really recognise that we think that patients are having these consequences dealt with during their follow-up, and they are not. What they're doing is having it noted in their notes of whatever format that is. It'll say, oh, that'll be a late effect of radiotherapy. And patients get referred to me and they'll say, why wasn't I referred 4 or 5 years ago? And I just have to go, I can't explain that. Often it's because whoever they are seeing, whether it be a CNS, a surgeon, an actual oncologist, if they don't think there's anything that can be done about it, they don't delve into it anymore. The other big problem is how do we decide whether that is problematic enough to have a referral to a service? And actually, it should be about the patient's subjective bother, not about whether that doctor or nurse specialist or whatever therapist they're seeing decides whether that's problematic. They may only get up once a night for a wee, but if they've never got up in the night for a wee and they cannot get back to sleep, and then they're not managing to get to work the next day because they're so tired, that is really major. Whereas they might only refer a patient on to a continence service if they're getting up 6-7 times a night. So it's really about, you know, looking at what is that patient's bother, but just recognising So it became so clear the more our service has been developed about what patients want and the patients that we've seen. And that's what I think is key, really. We think we can go into setting up these services on what we think we might need, but until you get those referrals in, you know, half the time I'm then saying to the patient, I'm going to have to go away and research this and see what I can do for you, because I've got nothing for you on this, but let me go and see what I can find in other complex conditions and long-term conditions, and what can I bring into this service to see if it can help you with whatever consequence you may have.
Now I know there's maybe lots of people out there who are maybe thinking, oh yeah, this sounds amazing, this is what the patients want or need, I'm going to set up a service. What's the first thing they need to do? How are they going to be supported? Emma, everyone needs to see Emma's face of just, I know.
So this is the hardest question, and I must get, I've had hundreds of emails on this. Myself and Lisa Durrant, who is another late effects consultant down in Taunton, we constantly bang our heads against a brick wall against this, because you know, there is no guidance out there. We set these services up. Lisa's service was set up by somebody previous to her, but then she took over it a year after it had set up, and that was a year after we'd set ours up. So very similar timings, really. But there's no guidance out there on this. So actually nobody knows how to set a service up. And you can only set a service up with what you've got access to. So first of all, it's about funding and where you're going to get that funding. Our service was funded by Macmillan in the first instance, and we're very grateful to Macmillan for that. And it's been trust funded since, although we've had other pots of money from Macmillan to expand it. But it's about seeing about what your need is, what your patients are. So you can go into this thinking, right, we need a gastroenterologist, we need a dietitian. But if your referrals aren't pelvis, you probably don't need that. If it's actually the fact that it's head and neck referrals you're getting more of, you might need more of a physiotherapist and more access to OTs. You don't know what you're going to need until you get those referrals in. The other thing is you need to tap into what services you've already got there. So when we set up, we literally, within the first couple of years, we're knocking on doors within our trust saying to like the fatigue service, the chronic pain team, the lymphedema team, can you help our patients? If I'm honest, a lot of time the doors were shut and said, no, we can't, because we unless you're going to pay for our service, which of course we don't have the money for that. So a lot of these services actually said to myself and my colleague who set the service up, Liz Stones, who's now retired, said, but we'll train you. So the amount of training that I have had from different services, I can't write it on it's massive. So it's really about just seeing what services you've already got out there and setting out on these services, because what you think at the start is not what you'll end up with, if I'm honest.
That's where the holistic
needs assessment comes in from the beginning. So even from pre-treatment, really, that's where you get baseline data to understand. This is something when I've worked with Lisa, she always said, whatever happens, even if it's nothing, just write it down, because in 10, 20 years' time, we'll know what they were like when they started. And exactly as you said, I think on treatment review, sometimes some people can be worried when a patient says, oh yes, I'm now getting up once a night. But if you don't know what they were like 6 months ago, you're not going to know, well actually, it hasn't changed. If it's still one a night, that means that the treatment's working, but nothing's really got worse. And I think that continuity of care, I think it is there, but it's not always, as you said, picked up. I think the follow-up so if, for example, if I do a follow-up call 2 weeks later and they've had their follow-up with their consultant, there might be some data there, but nothing, as you exactly said, nothing's been done about it. But until all those referral pathways are there, with your emails, what have you been telling people? Just go to all these services and talk to them.
What Lisa and I have set up a specialist interest group with the Society of Radiographers to try and really see how we can kind of coordinate this care, and we would love to come up with some guidelines along with the team at Derby and also the team at Gloucester, who have now got late effects services. We've tried to map what late effects services are out there throughout the UK, and we really would like to coordinate and get everybody's expertise on board, because it's not just about what Lisa and I think, and to try and say how, we're trying to put something together as to this is how you go about setting up a service, but only in our view. So we're trying to do that along with some guidance on how to manage late effects, because there just isn't education until, if I'm honest, until Cath really came along and said she could see how much I was struggling with these questions we were getting, and saying, well, let's try and put some kind of education together, because a lot of what I get as well asked is, well, what training do I need? Well, the master's modules that I did in pelvic radiation disease aren't even available anymore. They're not running anymore. A lot of the psychosexual stuff that I did, they're not. You can't get them modules anymore. So, it's hard to then say what should you go and get trained in, because actually, if you've got access to a lymphedema team, you might not need to be a specialist in lymphedema, whereas I've become a specialist in head and neck lymphedema, not because we haven't got a lymphedema team, we've got an amazing lymphedema team, but because I was already seeing these patients, and we recognised that actually if I could identify the lymphedema earlier on, I could make a real impact. So it's all this about this coordination and liaising with other allied health professionals and other, nursing professions, to really see what you can do for this joint working, to see what is best for the patient, rather than about constantly making separate referrals. So we really try now as a team to try and get the right people in the room at the right time, and that's just become more of like a dedicated clinic now, that we can actually have these specialists in the clinic at that one time.
Yeah, the multidisciplinary working is really important. I'm sure, with your head and neck consultant post before, that would have been something that obviously you've seen a lot, and the benefits for that kind of cohort. We've had a couple of guests on who've said, well, actually, wouldn't it be great if every patient had access to a dietitian to start with? Because there are little things you can tweak and change and make better, or help, with healthy eating advice and things like that. But I think, the special interest group I came to the last meeting, it's really good, even although I haven't seen that many patients with late effects, we don't have a late effect service, but it's interesting to learn, and I think that education element is really, really, really important. But it's good to have people like you and Lisa who are now shouting about it across the country a bit more. As you said, lots of patients have been missed. Have you found any services across the world that have kind of been set up a long time ago around late effects? I know you mentioned about the UK.
So the MD Anderson do quite a lot around late effects in the USA. I've had quite a lot of collaboration with them. But you see, because we're the National Health Service, other centres can get it, throughout the world. You pay for that service, so of course you can get access to a physiotherapist. Of course they want to get you involved in this long-term follow-up, but we just don't have that in the NHS. And because we're getting more and more patients on stratified follow-up and being discharged at possibly 1 year, 6 months even, this is where we're going to start missing these patients, because who's going to remember that it's a late effect? And I'm very much about patient education at the end of treatment, and you don't really, as a radiographer, probably want to say, actually, these are the late effects that you might get, but it is so important, because we cannot rely on the health professionals that they're going to see down the line to one, think, is this related to the radiotherapy or chemo, or actually think there's something that can be done about it. And I think that's key. So certainly with a lot of the patients now in our department, we're going to try and look at what can we really do treatment summaries are great, but have you seen a treatment summary when you actually give that to look at for a patient? It's like, wow, it's like a two-sided A4 piece of information. We want some real bullet points to say these are the late effects that you may get if you're a prostate patient or if you're a breast patient, and actually there are some things that can be done about it. And I think every department could do that. It's not just about us who's so lucky to have a late effects service. There's other things that you could be signposted to, different websites that you can be supported to offer this, even if it's not specific late effects management, there's lots of things that can be done.
When can late effects come about?
And what are the most common things that you see?
We don't see anybody until 6 months out of treatment. So there is, in the actual radiotherapy specification guidelines, they do talk about late effects at 3 months. There is no way we will see patients at 3 months, because we really do find that between that 3 to 6 months, to be fair, 3 to 9 months, it can often settle down. So, but we class a late effect as anything that is not an acute side effect that hasn't settled, or anything that develops from that 6 month mark. And that is where the real problem lies, because a lot of these develop once they're out of follow-up, 5 years, 10 years, 15 years out of treatment. I mean, the latest patient we've seen, I think, was 39 years out of treatment and has struggled all that time until they got to our service. And then was your question, what do we mainly see? Well, for pelvis patients, it's not surprising. It's your urinary problems, your bowel problems, the sexual dysfunction. Breast patients, it's predominantly peripheral. We see a lot with peripheral neuropathy from the chemo, but a lot of that is about pain and this persistent pain that patients get after treatment. A lot of that you have to work around the psychology of pain as well, and it's often linked to what they had from their surgery and their cancer diagnosis, and then the radiotherapy has come on board and caused a bit of radiation fibrosis, and it's caused that to be more problematic. With the head and necks, it's an absolute whole host from dry mouth, but it's all, if I'm honest, is linked to radiation fibrosis, and that is so problematic for the head and neck patients. It starts with a little bit, they don't move their necks and the mouths don't quite open as much, and then you see them 5 years later and they cannot open their mouth and they cannot move their necks. So at what point did that happen? If we can get in earlier to get some exercise in, to get these exercises going, can we prevent these late effects happening, which is what I'm trying to do with the head and neck cohort. Then we move on to what every patient who comes to the clinic has, regardless of tumour or treatment site, and that is fatigue and the psychological issues and the psychosocial issues, because these patients feel very different afterwards. They feel very alienated. A lot of the patients who have been living like this for a couple of years say to me, I'm so glad I can come and talk to somebody about it, because they get sick of telling their friends and family about it. So they actually say they're okay, because their friends and family will go, you're doing well, aren't you? Haven't you done well? So they feel like they should do well, and they feel like they can't actually say how they're feeling. They get a lot of this survivor's guilt, and that with a bit of post-traumatic stress from having a head and neck mass shell on can be phenomenal, really. But it's really important to recognise all of these things. But a lot of the power, I've always said in our service, is even for the patients that I don't necessarily think have not done a referrals here, I've not really done anything a bit more than sat and listen, but it's that power of listening to that patient, giving them that, our appointments are an hour long, giving them that platform to really talk about where they've been, but also to then help them to understand. And this is why it is key for therapeutic radiographers to be doing this role, because if you can pull that treatment plan out, or the old x-rays, the amount of times I go down to the bowels of our departments, pull out old x-rays to show them, this is why you have got this effect, look at where the high dose was. If you can lead them to understand, you can lead them to acceptance. And I've been known to reduce distress thermometer scales of 3 to 4 by doing nothing more than talking and listening and helping them to lead to acceptance. And that's not actually rocket science. It's just about giving them the power, and then they go out feeling a bit, well, maybe I will go and do some exercise then, and maybe I will try and change my diet to help me live better. And you're changing their lives rather than improving quality of life, without actually really doing more than sitting and listening and explaining. And that's where we have the power as therapeutic radiographers, because we know radiotherapy, we understand radiotherapy, and that's where I think we have a real power, really.
It's the best part of the job, isn't it? It's such a privilege.
Best part of the job, isn't it? It's such a privilege to listen to a patient's story. I think
we do forget that outside of
the radiotherapy department, where we're running an hour behind. We need them to have their bladder ready exactly when you want to get them in. There's so much more going on outside. They've walked here, or they're worried about not having their bladder full, something like that. It is a privilege, and giving them the time and space is really good.
We did an event recently for Trekstock, and we had some patients who'd had radiotherapy, and it was really insightful. Just listening to the patients about having the opportunity to talk about their late effects, and almost clarifying that they're not going mad, and that yes, that is as a result of their treatment. It's so important. One of the things that Naaman and I always advocate, so we do a lot of patient education around specifically radiotherapy, and we typically will say, ask your therapeutic radiographers to show you your radiotherapy treatment plan, so you can see what organs, and they may not necessarily have the insight into knowing about radiotherapy or how it works, but just see seeing visually where the radiation is passing through gives them some insight, which leads on nicely to Cath. How can we educate patients better as therapeutic radiographers or other healthcare professionals along that oncology pathway? Because I know you've done a lot of that through Prostate Cancer UK, haven't you?
Yeah, so educating the patients.
Yeah. Or the healthcare professionals specifically to then be able to educate the patients.
Emma sort of covered the key points in terms of patient education. I think it's really important that after they've had their treatment with us, and recognising that they might come back for further treatments, you know, it's not necessarily the end of treatment, you know, waiting till the very end of all the treatments they might be having, but recognising that, you know, supporting to follow up is a bit ad hoc. They might get the chance to sort of report their sort of things they're struggling with, but it might not necessarily be acted upon, and educating them to know where they can get support that they might need, and educating them to sort of understand, you know, what is a late effect, you know, understand why they might get these late effects and what they can do to help themselves, where they can source support from. The signposting is really important, I think, and just like Emma was saying, really, you know, having the confidence to be able to talk to them about these might be the potential late effects that you might experience. It's, you know, even acknowledging how it might impact on them personally. You know, as therapeutic radiographers, we do have that opportunity to build up a rapport with them, and certainly if a patient asks you about something they're concerned about, say, for example, their sexual well-being, you know, you can signpost them to support and things like that, but every patient will have different concerns depending on what's important to them in that regard, and you know, it might be more to do with, you know, they're feeling that there's a loss of intimacy with their partner because they're on androgen deprivation therapy, for example, and they're not really bothered about the, you know, the sort of sexual intercourse side of things, but they've lost that sort of, there's more of a relationship concern there. So yeah, I think just being able to just have that confidence to talk to patients about their concerns, and using your education as a therapeutic radiographer or indeed another practitioner to, you know, if you don't feel confident, there are courses out there that can help you gain that sort of knowledge and skill in sort of communication skills, and sort of using them to sort of develop empathy and sort of personalise your approaches to how you care and talk to someone. But yeah, the signposting and the end of treatment information, education on general sort of supported, you know, healthy living, general advice, but also there's sort of advice that you can give specific to their treatments as well that might help in terms of managing certain consequences. So, you know, with the for me, obviously with the prostate sort of side of things, you know, pelvic floor exercises are a big thing that are often talked about as being really important. And, you know, if you're talking about physical activity, you know, talking about that in the context of fatigue, but also in the context of maybe helping with some weight management, because obviously if there's a weight issue there, that can put pressure on the pelvic floor as well. And, you know, that it's kind of again, sort of helping them to understand why these things are important, to help them with things that matter to them, like the incontinence, like the sort of sexual dysfunction aspects, like the fatigue, that we've recognised and understood and shown that to them, that this is something that is really impacting on their life, and these are the sort of things that we can advise them.
Emma, can I ask, with kind of what Cath has said, how does that translate into your clinical experience? So is there anything that you wish other people had talked to patients about further along in the pathway? Or, you know, you're a therapeutic radiographer, what do you wish that people would talk to their patients about, or start to engage with them as they go through treatment?
I'd like radiographers and other health professionals to acknowledge that life will be different for the patient afterwards, of varying degrees. Some patients do have an amazing life afterwards and have no problems whatsoever, and actually think, oh, do you know what, I'm going to live the best life ever, I'm going to be really healthy. So, I don't mean grateful, but I do mean grateful that they're here and they've had this treatment. But actually for many patients it's very different afterwards. And it actually doesn't matter what you think is problematic to that patient. Every patient has a different scale of what that problem will be and what it will mean to them. I once did a talk to a group of head and neck consultants, surgeons and oncologists, and one of them said, I don't even consent for a dry mouth, because they don't all get a dry mouth and we can't do anything about it anyway. And he said to me, so I don't even bother. And I was just horrified by this, because I've had patients who've had to give up their jobs because of their dry mouth, that relationships have broken down because of just a dry mouth. And he said to me, what would you say? Do you think I should say to the patients? And I said, I think you need to say to every head and neck patient that the life will be different for you. And for head and neck patients, it definitely is different. I've not met one head and neck patient that doesn't have any effect after treatment. I don't mean they're not all managing it very well, because many of them do. But I think that's really important, that we acknowledge that life will be different for many patients afterwards, and that actually there are some things that can be done about it, but for others there are services out there that can help you to live better with how we've left you, really.
Cath, before I ask you about your top tips, just around the education side, it's just popped into my head. Do you think with promoting our profession and what we do, that educating kind of bystanders, so let's say family members or other people, about survivorship and late effects could help as well?
Definitely. I think knowing that sort of, the therapeutic radiographer can help their family member that's going through the treatment, and that they can seek advice and support from them in terms of moving forwards after their treatment, and where to get support if they struggle with anything. For the family member to play a role in, I think it's important, like Emma was saying, sometimes the conversations stop because it's kind of just a permanent thing almost. And I think if the family members can sort of, if we can play a role in educating the family members around the late consequences as well, I think that's important to help them understand what their loved ones might be going through. And also there's certain, the side effects will be impacting on them as well. And so it's important for them to understand why that might be. Can you hear me still? Yeah. Sorry. I was just going to say, Nayman, I thought you raised a really interesting point. It was something that popped into my head when I was thinking about the role of education for practitioners, and our sort of professional identity. And I really feel quite strongly about the importance of this topic being an absolutely integral part of our role as a therapeutic radiographer. I think we really do need to, work hard to be able to play a clear and visible role in the support of our patients affected by the consequences of cancer and its treatment, and not just see our role as sort of in the delivery of treatment and the management of acute effects. I think we really do, we have the skills, like Emma was saying, the knowledge to really sort of be able to sort of support patients moving forwards after their treatment, to play a role early on in that pathway of sending them off with the education, the skills, the knowledge, to really sort of feel supported moving into that sort of post-treatment survivorship sort of period. And we really can make a difference in that regard, I think. We obviously have the advanced, the specialist roles, such as Emma's in the late effects clinics, but I think, as Emma was saying, it shouldn't be the remit of the specialist therapeutic radiographer, or the on-treatment review radiographer. Everybody should be able to have a conversation with someone that about a particular effect that might be concerning them, not just in terms of the acute side effects, but you know, they will have consented and be not, you know, aware of possible late effects, and it might be things that are concerning them already whilst they're with us. And I do, you know, I do feel quite strongly that we need to ensure that we maintain our knowledge and skills in that area of patient support. And you know, it's like when IMRT and IGRT came in, we didn't have any qualms about upskilling and, you know, adding to our knowledge base around what they were, because that was you know, it was important, it was about driving our practice forwards. And I think the same parallel could be drawn with, you know, the importance of survivorship and care. You know, we need to embrace this sort of concept of it, you know, supporting patients into, you know, that sort of longer term period after they've had their treatment with us, for sure.
Oh, thank you, Cath. And I would like to think I certainly have witnessed it working nationally with HEIs who are training therapeutic radiographers, that this is becoming more part of undergraduate curriculum. I still think there's a long way that we've got to go, because as we know with a lot of things, you can implement curriculum changes, but until they see it out in practice, you know, it's very daunting for a student to start to have these conversations with patients if they've never seen a colleague who's already qualified having them. So there's definitely work that we can do, but it's reassuring at least. And I know there's a project being led by Health Education England that's just starting to start now with work streams called Ascend, which we'll put a link in. But essentially that's looking at providing oncology training across all of the pathway. So, you know, if you're in a generalised nursing role or a generalised physiotherapy course, how can you access more education specifically on oncology, which I think would have a massive impact if everyone was aware of, you know, can you imagine going to your physio appointment and having it recognised that certain symptoms are as a result of cancer treatment, rather than, oh, let's send you to your GP to see if they can help diagnose why you've got that. And hopefully that we'll see some changes from that perspective. We kind of we could go on and talk about this all night really easily, because I love it as much as you do, and I'm sure that people listening would be like, I just want to learn more. So we might have to have you both on again to do like a follow-up series. But Cath, what are your top 10 tips? You don't necessarily have to go for 10, maybe split it between you and Emma, but if there's kind of takeaway messages that you'd love people to kind of go away with, whether it's healthcare professionals, students, patients, is there anything that you'd love people to consider, and maybe promoting what you offer as an educator?
I think in terms of, I suppose, what's important in terms of that day-to-day care is to recognise the person as an individual when they're coming for treatment with you. And, you know, we're in a very, very sort of privileged, but also, you know, very well positioned sort of, you know, we have so much opportunity to be able to sort of pick up on any concerns that a patient might have. And yeah, I think just being, you know, even if you're not in a specialist role, I think it's really important to sort of, you know, always be mindful of the potential consequences of our cancer, of cancer and its treatment, in, you know, in not just the physical impact, but the psychosocial impact as well. And I think the more you become more knowledgeable of that through your own reading or sort of formal study you might do, I think that gives you increasing confidence to have conversations with patients. And it doesn't have to be about just, you know, starting that conversation with someone. It can be just about picking up on a cue and seeing it where it takes you, in terms of if they seem a bit deflated one day or mention a particular side effect that's getting them down. You know, just taking the time to explore a little bit more about why it's getting them down, and not just leaping straight into the, oh, well, I've got a, you know, we can refer you to the the review team, or there's a medication we can give you for this or that. You know, just taking the time to sort of explore that wider impact of what they might be struggling with. I think in terms of a top tip, you know, there is formal study opportunities out there, like MSc modules, mine, and there are others elsewhere as well, which is a good thing that we're getting better in that respect across the HEIs. But I think, you know, there is a lot of good resources out there, especially from the charities. So Pelvic Radiation Disease Association, Prostate Cancer UK, Macmillan, Breast Cancer Now, you know, just to name a few. But they often put on free events for healthcare professionals to learn more about these topics we've been discussing this evening, including, you know, how to talk to patients about the sort of health and well-being sort of things with, you know, that will help them sort of self-manage the consequences of certain side effects they might be experiencing. So I think a top tip would be to sort of, you know, it's easy to access sort of free education in this area, actually. I don't know what Em thinks on this. You know, at a general level, certainly, in terms of just taking the time to educate yourself and being more mindful of how our treatments can affect someone, and therefore I think that then gives you the confidence to talk about it. It would be my thought on that.
I think that's something that Naaman and I are really passionate about. If you just go through the back catalogue of people that we've had on the podcast, there's so many people from different charities or patients who, you know, they might have experienced a side effect from treatment, and they have obviously gone out and found resources that they could utilise. So Emma, top 5 tips, because you're sharing them. What would you say? And if you don't mind, I'm going to be a little bit prescriptive. What would you say to patients who have been 25 years sitting with a condition as a result of a consequence of treatment?
Okay, well, the first thing I really want to, a top tip is for all the therapeutic radiographers out there, is that we really should not be saying anymore that your treatment will carry on working for 2 weeks and then it'll get better, because for many it doesn't, of varying degrees. So it's not to frighten anybody, but actually I don't think we should be saying that. I think we should be saying that, you know, the treatment does carry on working for a little while afterwards, and it can take many months, if not years, for some of the side effects to settle, and life may be different afterwards. So I think that's really important, alongside with then signposting, like Cath said, if you haven't got a late effects service, to signpost to just say that there is other services out there that can help, such as even, you know, Macmillan is a really good place to start, if not Prostate UK, Breast Cancer Care, Proud, that, you know, the work. So all of those. And what did you read your question? What would I say to patients? Years down the line.
If you had a patient who'd had radiation therapy a long time ago, or chemotherapy, and they're like, oh, this is just a consequence of my treatment, but their quality of life is heavily impacted.
Yeah, so they wouldn't just say this is just a consequence, if I'm honest. This is where they would then start to unravel and tell you everything. And I have actually apologised to patients before and said, I am so sorry that, you know, we know so much more now about the late effects of treatment, but back then we didn't. So let's see what we can do to help you live better with how you've been left. The other thing what I think is really important is to really recognise, and I've forgotten what I was going to say now, my train of thought's gone. What was I going to say? Oh, it's gone. Oh dear. Yes. No, sorry, it's completely gone. It was there and it's just completely gone.
It's okay.
Sorry.
It's okay. Do you want me to ask the question
again? You can try.
Okay. So if you had a patient who had
I've got it.
a late effect.
Sorry. So the other thing I was going to say is that what's really important is to remember that we can't always fix everything, but it's about listening to the patient, helping them to understand, like I said earlier, how they've been left, and then helping them lead towards that acceptance as to how things are now, and then helping them to live better with how we've left them. But often I think, particularly as radiographers, certainly when I was doing on-treatment review, you always feel like you've got to have an answer. You feel like you've got to be able to fix that acute, let's give you this medication, let's do this. And actually, with a lot of late effects, you can't do that. You know, radiation fibrosis, it's the radiotherapy is the gift that keeps on giving. It's this evergreen monster that keeps on affecting patients. And, you know, we can do all we can to try and help them live better with that. But the patients have got to be aware that for some of these things, they are lifelong. So it's just about not rushing in there thinking you can fix it. And also not stepping back and thinking, well, I can't possibly talk about that and open that can of worms because I know I can't fix it. Because actually it's just that power of listening to the patient is really important. And a little bit what Cath said as well about then personalising that to the patient and really getting to the, you know, to the depths of actually we can understand why it's so important to you, a dry mouth, because of this, you know, whereas to somebody else it might not be as important. But it's about personalising their late effects to them, really, if that makes sense.
I've thought of another one that Emma and I were talking about before the podcast started, which was that thing, Emma, about sort of that message around just because our, you know, like this, certainly when things are published around a particular technical advance, they report on low levels of toxicity. And what they often and most often mean is those higher grades of toxicity that would, you know, likely make a new advance in treatment probably not feasible. You know, they'd step back from it a bit because they're seeing the higher grades of toxicity that they don't want to see. But that doesn't mean that our treatments, our advances in treatment are side effect free. Was the other thing we were talking about, wasn't it, Em? And that, you know, we are still with the lower levels of toxicity. You know, like when they say, oh, the majority of patients only had grade 1 RTOG side effect, you know, for urinary symptoms, for example, urinary bother. That grade 1, if you look at what that actually means, the definition of it, if you had that for the rest of your life, that would lead to potentially a significant level of bother. So I think that was the other thing we were sort of wanted to say, wasn't it? That, you know, don't be sort of, you know, I think we can sort of think that with our advanced techniques now that we're sort of, you know, we haven't got the side effects that we used to, and we haven't in the sense of the real sort of severe ones. But the fibrosis in particular, which has such a massive impact, is still going to happen. I don't know whether you wanted to add anything to that, Em, because it was your point that you made to me earlier.
Yeah, it was just really, I mean, we've got patients going to the Christie at the minute for proton therapy, and we're just seeing their effects, but at a different time point. I mean, that's more in the acute setting, but they're still there because actually, where their cancer is in the first place, we still need to get that dose in. So actually, these late effects are never going to go away. They're just going to maybe pop up and be recognised and be more severe to certain patients at varying time points, but they're always going to be there because it's radiation that's causing the problem.
Oh, thank you. That's a really important point to focus on, and obviously leading forward for anyone listening who is engaging in research and evidence base, it's good to have that perspective and make sure that that's kind of recognised, especially as COVID has created changes to practice. It's important to consider and advances in software. And if we look just specifically within radiotherapy, MR Linacs, everyone goes, you know, if we can really focus the dose, you still have to get the dose to that area that you are essentially treating. So it's a really good point to finish on. So thank you again so much for joining us. It's been absolutely amazing, and I'm sure anyone listening who's working in oncology would have got a lot out of it, as well as any patients who potentially are going through treatment or yet to have treatment. So thank you for listening to Rad Chat. Your hosts today have been myself, Jo McNamara, and my co-host name, Angelika Anderson. A huge thank you to our guests, Catherine Holborn and Emma Hallam. So head over to our YouTube page to see a live recording of this podcast. And if you are looking at YouTube and wondering where Cath is. I'm really sorry her camera didn't work, and so we apologise. We did have a chuckle at the start that it was the educators that were struggling with the IT, so we apologise for that, but we'll superimpose a really nice picture of Cath's face somewhere, I'm sure. If you're utilising this podcast for CPD purposes, please answer the reflective questions posted along with it. There'll also be the resources and literature that we've discussed, and so to receive your accredited CPD certificate, please just complete the Google form. So our next guest to feature will be Victoria Cuthill, who will be discussing genomics. So thank you so much for listening. Take care and good night.